Professor Jill Harvey, who's a professor in health management at Manchester Uni, but she's been a visiting professor in Adelaide since 2013, and was recently announced she's going to be staying with us, well, till around 2018, hopefully, at a minimum, which is great news. And so for those of you who've seen Jill's background, it's quite an impressive background. She's on the official list of high-cited researchers. She's the previous director of the Royal College of Nurses Quality Improvement Programme and the co-developer of the Promoting Action on Research Implementation in Health Services framework. And so with that, I'll hand over to Jill, who will give us her views on academic health services partnerships as a translational strategy. Thanks, Jill.
Thanks, John, and for those people listening, thank you for the invitation. It's a pleasure to be involved in this seminar series, and you'll already have guessed that you've got another Northern English accent to contend with for the next 30 minutes or so. So that may be a point where you need to tell me to clarify if there's anything that's not clear. So I deliberately made the title a little bit controversial, partly because of the continuing or the growing interest in creating collaborative partnerships between academic health centres and local health services to try and address issues around translating research into healthcare decision making. And also because it's an area that I've been involved in the UK since 2008, and I'll draw on some of that, both empirical and experiential evidence as we go through the presentation. So in terms of the areas that I thought I'd cover in the presentation, a little bit of background around just generally why the issue of translation is such a key issue, a bit of context in terms of where these different collaborations are being introduced and tried, what might be some of the assumptions that underpin them, and then what have we learned so far, really from the last 7 or 8 years. And again, both of those I'll draw on my own experience, one within a Faculty of Health Sciences and the other more broadly from the work within England, where these collaborative arrangements have been in place since 2008. So really, in terms of starting, I think if you look back over the last 15 to 20 years, what we see is this challenge of how to bring healthcare practice, healthcare policy and decision making in general in line with what we know is best practice from available research evidence. And really, much of the original discussion around this is linked to work in the US, when in 2000 the Institute of Medicine held a clinical research roundtable to address the concern that scientific research was not translating to human benefit. And they drew on this 1998 study from Schuster and colleagues, where from a massive review of records, they concluded that up to half of healthcare in the US was not in line with the best available evidence. And that really marked the start of debates around how to address translation and terms that we've now become familiar with, like the gaps or the T1, T2 translation gaps. So from bench through to clinical application, through to routine healthcare. And again, you've probably seen lots of elaborations on that, where now people talk about T1, T2, T3, T4, but they're all about stages within the process of translation. And interestingly, if you look in Australia, 14 years later, we saw the results from the Care Track study, which followed a similar methodology to the work that Schuster had done, and as an overall finding concluded that patients received care judged to be appropriate. That's in line with evidence-based guidelines 57% of the time. So really very similar findings to those from 14 years earlier, and probably reinforcing that this thing we call translation or knowledge translation, it is an enduring issue within health systems across the world. And one of the sort of points in which to frame some of this is looking at how people have conceptualized the knowledge to practice relationship. And in much of the literature, I'd suggest the traditional view has been that it's a problem of transferring it from the producers of the evidence, the researchers, to those people who we want to use it, the decision makers, whether they're clinical, whether they're patients, whether they're policy makers or managers. And much of the discussion around translation tends to use language like pipelines and gaps, so indicating that there's a sort of flow or a push of research evidence from the original production of it through to finding ways to make it more accessible and more usable by decision makers. And we've seen the growth of the whole evidence synthesis work around systematic reviews, clinical guidelines, and trying to find ways to make research more accessible, more synthesized, and skilling people up to use that. And we often talk about the gaps between the different communities involved or the different groups involved, growing awareness of what some of the barriers are or what some of the reasons for those gaps are, but it's still fundamentally seen as a pipeline that flows from original discovery research through to those end users of it. And I think if we look at some of the assumptions that underpin that pipeline approach, to some extent they've really been challenged by the research that's been done so far on implementation and translation of research evidence into practice. Because what we know from the growing evidence base around implementation is that flow does not take place in a straightforward or a linear way, and that the ways in which evidence finds its way into decision making are incredibly complex, that they're very rarely rational, there are very strong contextual effects. So what works in terms of implementation in one setting may work very differently or not work in another setting, whether it's up the road or whether it's in another state or another country. That however good the research evidence is, it doesn't mean automatically that people will be convinced or persuaded to use it. And at a very general level, what we can see is that the more interactive, the more contextually sensitive implementation and translation strategies are, the greater the effectiveness we tend to see. And there's also evidence around the beneficial effect of having individuals in a designated role to help facilitate or support translation, whether they're opinion leaders or knowledge brokers or what some people would call facilitators. So the message is that we may envisage it as a fairly straightforward or a fairly linear process, as a pipeline model would suggest, but in practice it tends to be messy, it tends to be difficult and unpredictable. And that, I think, is a lot of the influence between trying to think differently around the relationship between evidence-based knowledge and practice. And some researchers, some theorists would say we actually need to stop seeing it as a knowledge transfer problem and think about it as a knowledge production or a knowledge processing problem, and not create this artificial separation between research and practice. And that really is some of the thinking that underpins these more collaborative models of researchers and practitioners working together in the joint production and use of evidence in practice. So again, in the literature, what we see is a new dialogue really around knowledge mobilization or knowledge interaction, engaged scholarship, co-production, and really emphasizing that we need to be more responsive and that we should focus on producing knowledge that answers questions that matter from a health service and patient population perspective. And to me, that one consequence of that has been the deliberate creation of these academic health service partnerships to generate the type of joint or collaborative working between higher education and health services to enable some of that to happen. And some examples of that would be in the States. Organisations like the Veterans Administration have really led that joint situating of research and practice within their query programme, their Quality Enhancement Research Initiative, published really widely on it and done a lot of work around linking research and clinical decision making. Similarly, in the Netherlands, within public health, in England, what are called Clark's Collaborations for Leadership in Applied Health Research and Care, and which I'll come back to later in the presentation. And clearly, in Australia, recently we've had the announcement around the Advanced Health Research and Translation Centres, and 4 set up initially, 2 in Melbourne, 1 in Sydney and 1 in South Australia. So it's definitely a growing movement that we're seeing across many healthcare systems. And, you know, remember that they've come from a view that we need collaboration to encourage translation of research evidence to occur more regularly, in a more timely fashion and more effectively. So underpinning the ideas and the models, we could suggest that there are some assumptions around the benefits of bringing academic and health service decision makers together in these forms of collaboration. One of which would be that they share a common goal, a common purpose, that they're similarly committed to achieving better translation, and that by collaborating in the way that's suggested, that we'll create something that is better than what we've got now, and ideally something where the whole is greater than the sum of the parts. And it's really exploring some of these propositions or assumptions that I'll try and do as we go through the rest of the presentation. In doing that, you know, it is a relatively new area of study in healthcare. So the evidence is emerging as these things are taking shape and beginning to start working within health systems. So I'm very much going to draw on my own experience, both from being involved in these types of ventures and being involved in research in the Clarks within in England. And the two areas that I'll particularly focus on is one, from within a Faculty of Health Sciences perspective and exploring the views of staff within an academic Faculty of Health Sciences. And then the second is both my own experience, my own research, and the wider research evidence around the clerks in England. The first one is very much around the views of staff within a Faculty of Health Sciences, which is actually a really diverse environment. So, you know, typically when these translational networks between academic health and health service are set up, what you see is that there's a health sciences group brought together to be involved, but that can actually represent a really diverse range of disciplines. And so one of the projects that we've done is actually look at what translation means to staff within a Faculty of Health Sciences, and undertook a series of interviews with representatives from all of the schools within a faculty, so from medicine through to allied health, nursing, etc. Really to explore what the views of translation were, what people already did, and what were some of the enablers and the barriers. And we're actually using that within our own university to develop a more consistent strategy around translational science. And I'm not going to go through all of this in great detail, but just to highlight that in terms of what we found from the initial work, that there is huge diversity in terms of views, opinions, knowledge, confidence, and commitment to engage in knowledge translation activity. And that's influenced by a whole host of factors, including what people understand it to mean and the extent to which they've been prepared as researchers or as teachers to engage with it, whether it's a conscious activity or whether people think it's something that happens as a result of them undertaking their research and doing the end stage process of dissemination of their research. I think a really significant finding was around the metrics by which people are judged in an academic environment, and that those metrics do not necessarily align with stakeholder engagement or engagement with health services to address issues of translation and service improvement. And so what we saw within this research was there isn't a consistent view across a single group of researchers within a faculty, that some people see it as the reason that they conduct research, the reason why they're engaged in health services research. Other people see it as something that, you know, may be a good thing to do, but it's not going to be the thing that they're judged on within their own academic community. And that's partly because of the system level metrics around research, around funding criteria, etc., etc. So I think, you know, going back to the first point around underlying assumptions that people want to engage in these types of collaborations, and that they know how to engage, that there's a lot of work to do around that, even within an academic environment, that it's not as straightforward as engaging and thinking that people will want to do it or know how to do it. And that was very much a finding within the Clark's research, which I'll talk a little bit more about now. So in England, in 2005, 2006, similar discussions were taking place to those that had been held in the US with the Institute of Medicine. And we had a number of national reviews around the translational challenge and how to address it. And one of the consequences of that was the establishment of these collaborations for leadership in applied health research and care. which were first created in 2008 as total partnerships between universities and local health service providers. So it was open to a competitive bidding process, and 9 clerks were funded for a 5-year period from 2008 to 2013, with a total per clerk, the total funding allocated was 20 million pounds, so 40 million Australian dollars. And I'll say a little bit more around how that money came to be. At the end of the first 5 years, a commitment was made to continue the funding of clerks, and again it went out to competitive bidding, and 13 more were funded, so they'll run from 2014 for another 5 years. And most of the original clerks were refunded, but with some changing of boundaries due to ongoing and persistent reorganisation of health services at a national and a regional level. All of the clerks have had 3 main objectives, which is to conduct high quality applied health research, to implement the findings from that research in practice, and to build capacity within NHS organisations to engage with and apply research. And at the same time of funding the clerks, our national research programme, the National Institute for Health Research, commissioned 4 external evaluations of the clerks in the first 5-year period. So each clerk had to have a strategy for internal evaluation, but there were also these 4 national evaluation programmes, many of which have now started to publish their findings in journals like Implementation Science, Qualitative Health Research, Journal of Health Services Research and Policy. And I've put a few examples up there, but I'm very happy to pull together references as well if people are interested. The clerk that I have worked within is the one in Greater Manchester, which was a collaboration between the University of Manchester and all 19 NHS organisations within the region. It deliberately focused on cardiovascular health and was funded for £20 million over the first 5 years. Half of that money came from the National Research Funder, the NIHR, and there had to be £10 million match funding, which in our case came from the 10 primary care organisations within Greater Manchester. What we saw within the clerk is that there have been multiple examples of success at a project level, and I'll very briefly describe one as an example of that. But the question that we were really keen to understand is, has there been any benefit of creating this deliberate network? So has in Greater Manchester, has the clerk been able to leverage the benefits of collaboration over and above funding these individual projects at a local clinical level? And that's the question that I'll try and address. But to just give you a taster of the type of projects that were undertaken at a local level to address evidence practice gaps or areas where improvement could be achieved. One of the projects that we set up under the broad umbrella of cardiovascular health was around the identification and management of chronic kidney disease in primary care. And using available data, we knew what the expected prevalence of CKD was on GP practice registers, and we also knew what the actual prevalence rate was. And we could see that there was, on average, a 2% difference, which if you extrapolate that to a population level, suggested that there were probably 40,000 people in Greater Manchester with undiagnosed chronic kidney disease. So we knew there was potential to improve, and we also knew from the pay for performance data that where people were on a practice register with CKD, that their blood pressure management was not necessarily in line with research evidence. So we set up a study, an implementation research study, to work with a number of general practice organisations over a period of time, and really introduced an implementation strategy that was multifaceted, combined interactive education with audit and feedback, with agreed targets for improvement, addressing local context issues using plan, do, study, act cycles, providing external facilitator support. So those were people who came from the clerk to go and work with the practices, and reimbursing staff time to be involved in the study. And this is fairly typical of a number of the clerk projects. Saw increases in terms of identification of people on CKD registers, and we used on National Institute for Care Excellence, NICE, we used their clinical guidelines around CKD, and saw that there were improvements in terms of the management of patients to NICE blood pressure targets. So overall, we saw an increase of 30% of identification of patients with CKD, and as the slide shows, an improvement in managing those patients' blood pressure. And again, that's just another illustration. I'll skip over the next slide just for time, but in evaluating our own internal evaluation of the projects, we also did some embedded process evaluation, and saw that some of the infrastructure that was created by the clerk, like support from external facilitators, setting up an audit and feedback system, providing some financial reimbursement, were really positive, important enabling factors in the practices that were engaged in it. We still saw variation, and that was typically around internal practice factors relating to leadership, engagement, all of those contextual factors that we know from research are important. But we were able to capture that learning in an improvement guide, and have continued to roll out the work across other general practices within Greater Manchester, including developing some audit software that could be used to support the identification of patients. But the second question was really around, okay, did the actual network structure of the clerk enable that type of work to happen, or could it have happened just as successfully without the infrastructure of a clerk as a translational network? So over the first 3 years of the clerk, we undertook a retrospective study, a longitudinal study, to actually look at some of the issues relating to the design and the way in which the Greater Manchester clerk was set up, particularly focusing on the structure, the governance, the decision-making processes, and the ways in which knowledge was moving around the system. And again, just to sort of set the scene for that, the whole ethos was around a collaboration, but the way in which the clerk was originally structured is how it's presented in this slide. So we had a network board with all the representatives from the health services and from the academic institution. We had a clerk director and deputy director from the university, And then we had two separate strands of work, one which was around conducting applied health research, and the other which was concerned with implementing that research into the local health service. And I'll talk a bit around the consequences of that initial structure as I go through the last part of the presentation. So the board structure was very much a representative board. So it's a large board. It had, as I said, all of the stakeholder organisations, both those financially supporting the clerk and those not providing any financial input represented. But when we studied the discussions that were documented in the minutes of the clerk, a number of really sort of important and interesting issues emerged. One was a very sort of practical level, that the NHS partners were not consistent or frequent attenders at board meetings. So a quarter of the board meetings in the first 3 years weren't even quorate because partner organisations didn't attend. And out of the 10 primary care organisations that were funding the clerk, less than half attended the meetings regularly. So only 5 attended 6 or more meetings. All of the rest attended somewhere between no meetings and 6 meetings. So given that they were investing financially in the clerk, their level of engagement in it was relatively poor. In terms of decision making, really from day zero, it was really very clear that the priorities between the university members and between the health service members were quite different. So the initial selection of cardiovascular health and the specific projects within that was driven by the existing research strengths in the university, and they didn't always match the health service priorities, which were around policy, service improvement targets, funding linked to service improvement, and there was very little ability or flexibility to respond to that. The research programme was pretty much set and it remained fixed, and so it was really hard to be responsive to local service priorities and questions that could have been really interesting, important research questions. And that structure that I showed you on the slide really created fairly significant divisions internally within the research, within the university. So the applied research, the research strand, was very much the domain of the health service researchers, and the implementation strand was the organisational studies, business school management researchers, and those two remained separate throughout the 5 years of the clerk. And it was very much the director, the deputy director roles that acted as the points of communication. So there was really very limited opportunity to bridge disciplinary boundaries, and in some cases those boundaries were strengthened, they became more significant, and some new boundaries formed even between individual project teams. And what emerged as a really important finding was that there was so much energy and attention focused on external movement of knowledge from the university to the health service, but the need for internal communication, internal knowledge mobilisation was really significant, but it was overlooked, and it became really a barrier within the functioning of the clerk as a whole. And I think looking at the other national evaluations across the 9 clerks, you can see very similar issues emerging from them. One is around the incredibly strong epistemic boundaries that exist between different disciplines within healthcare and between healthcare researchers and healthcare decision makers. That where there was a previous history of partnership working within a local health economy, that was a really important starting point for the clerks, where that relationship was created to get the funding for a clerk. It was often problematic, particularly if the university became the physical base for the clerk and was led by university academics. So some clerks located themselves within a health service organisation, and they tended to be the ones where you saw a much more collaborative, a true collaborative way of working, and a commitment to real co-production of research evidence and use. I think in all of them that they've been seen as a natural experiment, and there has been a very emergent process. And you know, it'd be interesting to look at the second wave of clerks and whether the learning from the first 5 years has been transferred to those. But I think you can't underestimate the influence of past history, the influence of opinion leaders within a local collaborative arrangement, and how that influences the course that these type of partnerships take over time. So conscious of the time, I think from the research, particularly the research into the clerks, it's really clear that just creating these types of translational networks in itself is not the solution. It's not going to solve the translational issue. And in the words of Mintzberg, we know that form follows function. And I think there's a real danger in these types of initiatives that we set up the structure, we set up the governance without insufficient attention to why are we getting together, what are our values, what are our purpose, what are our goals. And that really needs to be the starting point, and then think around the structures and the governance arrangements that will enable that. And really importantly, think about both the internal investment that's needed and the internal communication and knowledge mobilisation, as well as that more traditional academic to health service process of translation. So in conclusion, I think it's really important and it's really encouraging that people are thinking about translational issues at this organisational health system level, as well as at the individual decision maker practitioner level, but that we can't expect structural solutions to solve a problem that's been present for many years and is likely to be there for many years to come. You know, I remember reading a paper when I first got engaged in this work in the 90s from Andy Oxman, talking about the fact that there are no magic bullets, and my sense is we keep trying to find them, and actually we've got to acknowledge that these are complex issues and we're not going to find straightforward, simple solutions to them. So I should probably stop there, and yeah, open it up. Really happy to take any questions.
Thanks, Jill. That was great. You can imagine us all clapping in the background. Yeah, thanks. So Ruth Pitts has asked a question which is along the lines that I was thinking. So she's asked, did the clerks or similar organisations have formal monitoring and evaluation frameworks established from the beginning of their operations, or did the research projects that you discussed emerge more organically over time?
So in relation to the first question, there was formal monitoring, but the formal monitoring was via the National Institute for Health Research, and again, I think I didn't talk about it, but the relationship of the overall commissioner at a national research level, I think, had a significant influence, because they use really quite conventional metrics to monitor the clerks. So they were looking at research outputs. So for academics working in the clerk, there was that dual challenge of trying to meet what are seen as more traditional academic metrics around publications in high value research peer-reviewed journals. And to be honest, health service partners, that doesn't tick their box at all. They want solutions to their local priorities sorting. And so the project, like the one I described, was an emergent one in relation to an issue that was identified at a local population level. And as a person working with one foot in an academic environment and one foot within that local implementation setting, you know, you're constantly juggling trying to meet two different sets of performance metrics, really.
And so you mentioned there about it was defined at a local population level. So
yeah,
how exactly was that that prioritization or the decision?
Yeah, so I mean, the Clerk in Manchester, the Clerk had already decided it was going to focus on cardiovascular health, but looking at the pay for performance information, which is the quality and outcomes framework, then obviously local health services they're interested in indicators that were on that because they get financially reimbursed to meet them. And because chronic kidney disease in this example was a relatively new disease state that was included on the register, that for many practices it was an area that came to them that they didn't have a lot of prior experience or knowledge in how to manage it in a primary care setting, yet they had targets that they were being incentivized to meet. So, you know, that was very much an alignment of local motivation, but also there was a clear potential to improve how things were currently done.
Okay. Barbara from Geraldton asks, which tool do you use for the local context assessment?
Yeah.
Did the audit software automatically extract the data, or was it a manual auditing process?
Yeah, okay, so first question, which tool did we use for the local context assessment? We looked at 3 context assessment instruments, and one of the things that I haven't said is within the Clerk as a whole, we developed a sort of working model for the implementation project that was based upon the Paris framework and on the model for improvement from the Institute for Healthcare Improvement. So the context assessment instruments that we looked at were the Alberta Context Tool, the Context Assessment Index that was developed by Brenda McCormack, and one called ORCA, Organisational Readiness for Change Assessment, which was developed by Christian Helfrich from the Veterans Administration. And actually, this is probably going against all the rules of what we should have done, but we created a really short context assessment from the items within those instruments that we felt suited the local setting. So we didn't use a pre-validated instrument in its entirety. We just developed a local diagnostic that we used to then discuss with the practices where we thought their likely barriers were going to be in terms of introducing the improvement project at a local level. So it was done in a very iterative way with the facilitators and with the practices. And then the data extraction in the first wave of activity, we had to do that manually, and that took virtually it took 9 out of the 12 months of the project because most practices were using different systems. But then, as actually one of the really positive things that came out was that another Clerk had developed a software program to extract the data around CKD. So we joined forces with them. We shared our implementation knowledge with them. They shared their audit software, and we created this tool called Impact, which is the data extraction plus the improvement manual or the improvement program for practices to use once they've got that data extracted.
So is that specific to CKD, or could it be general?
Yeah, it's specific to CKD, that, yeah.
Right.
Yeah.
Ruth just had a quick follow-up question about the attendance at board meetings.
Yeah.
Whether this data was collected formally as part of the monitoring, or you were just fortunate to have that data available?
Yeah, it wasn't collected. So within the clerk itself, it wasn't something that people looked at. We collected it as part of the study of what was happening at that level. Interestingly, I have to say though that you know, if I look in Manchester and I'm still connected to the work there, I think the learning from the evaluation influenced the way that the Clark Mark II is being designed, because the structure is very different and they have an ongoing evaluation at that board level of how they're functioning. So there's a researcher attached to them doing an ongoing longitudinal study of the decision making at that level.
Okay, I'll just go to Oliver, who's just had a follow-up question. So did the NHS trust that didn't attend, oh, it was the primary care organisations?
Yeah, primary care, they were primary care trusts at the time.
Sorry, that didn't attend the board meetings. Did they have any explanations or excuses?
No, and you know, I didn't have time to go into the full story of what happened, but when the clerks were set up in 2018, the English financial economy was relatively healthy, and particularly in healthcare, because the Labour government had invested quite significantly in healthcare. So all of the primary care trusts, as they were at the time, committed to investing in money in the clerk. And but there were definitely these 2-3 of the 10 who really from day zero didn't engage in board meetings or in putting forward suggestions for work that they wanted to be done. And then 2 years into the clerk, the economic situation in the UK was looking very different. You know, budgets were really tight, people needed to cut back. And so what actually happened in Manchester is, over the period of about 18 months, 6 out of the 10 primary care organisations withdrew their funding. So by 2012, there were only 5 primary care trusts who were still making a financial commitment to the clerk. And the narrative, if you read anything about the clerk, was that the economic downturn forced primary care organisations to withdraw funding from the collaboration. But when you actually read the documented evidence, that some of those primary care organisations from the very first meeting had said, why is all the money going into topics X, Y, and Z? Because at a local level, these are our priorities. And the leadership of the clerk was not prepared to change the predefined research programme at all. So nothing that had been established at day one was really significantly changed in response to the questions that came from a service level. So it's difficult to say whether that caused some organisations to disengage, both in terms of attendance and also later financial commitment. But there is a strong sense in the narrative that local health service organisations didn't feel that the clerk was responding to their immediate priorities in terms of research questions.
So if the Manchester Clerk is one that's been extended, has that aspect changed, or is it has it changed since 2014?
I mean, in terms of the actual way in which the Clerk is set up and running, it's definitely changed, and the way in which it's funded has changed as well. So there still has to be matched funding, but that funding this time round, some comes from the broad range of health service organisations, both primary care, acute care, specialist. Some comes from industry. It's a much more diverse set of funding relationships that are in place.
Okay. Abby Haynes asks, did the researchers who are involved in the Clerk, did they have real-world experience, such as practitioner backgrounds or spending time working in healthcare services?
Yeah. I would say the researchers who were involved in the more direct implementation research activity, yes, and we actually seconded quite a lot of people from the local health service to come in and work with the Clerk for a period of 1, 2, 3 years. So I really think we did build capacity in terms of how you introduce change, introduce research evidence at a clinical level, and that has helped to sustain some of the work within the local organisations. For me, that structure that put the people undertaking the applied health research separate from all of the engagement with the health service was probably a major design mistake, so the applied health researchers continued to work in the way that they'd always worked. That's a gross generalisation, but if you look overall, that is what happened.
Okay. Rhys Hinchcliffe asks, did the Clerks merely provide a structure to enable a series of project-based academic practitioner partnerships, or did they also collaboratively develop a vision for the future health systems of their regional areas?
So I would say, on the whole, that in the first 5 years, they provided a structure or a vehicle for undertaking local projects. I think there are 1 or 2 exceptions, and so all of the external evaluations of the Clerks that were done included a qualitative element in them, and there are some really good examples within some of those qualitative case studies of where there was a much stronger engagement with local populations and with creating a vision. And there were deliberate attempts to bring all 9 Clerks together. But I'm still a little bit sceptical of whether they, and maybe it's not attainable within 5 years, whether they leverage the benefit that you would expect from the level of funding that was put in.
Okay. I just wanted to ask you to think about it in the context of the Australian healthcare system, and you've been here for 2 years, and just wondering what, you're talking about translation within the faculty, but more broadly, what your kind of thoughts about how Australia compares to the UK, what could be translated from the UK to an Australian context. I was specifically interested in your comments based on the evidence, but also your thoughts about the need for facilitation, and what's your experience or in relation to how that's been used in Australia.
Yeah. So I think I think Australia is probably following the direction of travel of what other countries, including the UK, have done. I think one of the issues is that when you use the word translation, for some people that's very much seen at the early stage translation, and that much more biomedical research, so getting from discovery to clinical application. Whereas in the Clarks, I think there was a real expectation that it was about implementation at the level of clinical decision making and health service decision making. So I think in terms of the translation centres in Australia, it will be very interesting to see how they actually conceptualise translation, and the extent to which there is a focus on changing health care at a clinical population level through really interactive processes of implementation and evaluation. And within the Clarks, we consciously trained people in those facilitative knowledge broker roles, because I think there's really good evidence that it does make a difference. I think there's a lot we don't know around, what type of person, the dose, the frequency of the interaction, but there is good evidence that if you put people in those roles, the uptake of evidence is much more likely. And a really good systematic review actually from primary care, that having people in those designated roles increases the likelihood of uptake of clinical guidelines by about 3 times. Yeah. All
right. Okay. Well, it's gone over our allotted time, so it's been really good. Thanks very much for that, Jill. And like I say, all the presentation and the questions and everything will be uploaded onto the association website. Sorry, we can't give you. Well, I can give you a clap. But,
thank you.
No one else. So, an anonymous attendee said, "Thanks very much, Jill," and I'm sure everyone else is thinking the same. So, thanks very much, and thank everyone for attending.